Welcome to the EmpowerPatientPodcast.com show. I'm Karen Jagoda. My guest today is Dr. Adam Rogerz. He's the CEO of NervGen Pharma, NervGen.com. And it's been more than a year since I spoke with NervGen, and a lot has happened since then, including some interesting positive data readout and new leadership. So I want to welcome you to the show today, Adam. I appreciate you taking some time to be with us.
Thank you, Karen. It's a pleasure to be here with you.
Thank you. The topic today is spinal cord injury. So talk to us a little bit about why spinal cord injury is such a difficult condition to treat.
Well, first of all, spinal cord injury is not only a very large market, but it's also a very unserved market. Our mission at NervGen is to improve the lives of individuals with spinal cord injury. And there are roughly in the United States 310,000 individuals with spinal cord injury and about 18,000, roughly 18.5 thousand new cases per year. And, it's such a difficult injury to treat because other than largely exercise and physical therapy, there are absolutely no approved pharmacologic treatments that promote functional repair for individuals that have suffered a spinal cord injury. So, Karen, basically what you have is you've got an enormous unmet medical need, a big population, no effective treatment, and an injury that really upends not only an individual's life, but their entire family. It really throws everyone in their family into disarray because you now have a person that's having difficulty with function. I'm a physician by training. I practiced for nearly 20 years, and in the medical world, we have always been taught that when a neuron is damaged, as what occurs in spinal cord injury, the neuron becomes dystrophic and cannot regenerate. So the medical community has always believed, and I was taught this, and even in my practice, that once you have a damaged neuron, that neuron is dead. So the problem that we have to solve here is really, it's twofold. Number one, are neurons still viable after a central nervous system or a CNS injury? And number two, if the neuron is viable, how can we get that neuron to sprout, remyelinate, regrow, so we can gain some function in the end organ that neuron is supposed to innervate? NervGen's scientific founder, the late Dr. Jerry Silver, dedicated his entire career to understanding what prevented the central nervous system from repairing itself. And what he identified, and this gets at the root of your question, is he identified a class of molecules known as chondroitin sulfate proteoglycans. We abbreviate it as CSPGs. And CSPGs are extremely inhibitory and become present and proliferate after an injury. And that's really what prevents or blocks neurons from regenerating after a CNS injury. Dr. Silver created what we now know today, and at NervGen we call it NVG-291, and this interferes with the inhibitory actions of CSPGs. And NVG-291, the mission is, and the goal of the drug is to enable the nervous system to repair itself.
Tell us about how that works. Is it an injection? Is it a one-shot deal? How is the treatment administered?
We administer it in a very convenient way. It is administered as a subcutaneous injection on a daily basis. And in the clinical trial, it was given once daily for 12 weeks. And so it's very easy. Everyone can administer an injection. It's typically given in the abdomen, and it's a painless injection. It's very easy to give. It's very much like if you were a diabetic, you would give yourself an insulin shot. Many people today use Wegovy or other medications. Those are abdominal as well, but it's a very easy abdominal subcutaneous injection.
So you recently announced some clinical trial results for NVG-291. So what can you tell us about the key findings?
Sure. The key findings were based, the key finding that we're seeing is that we are having an improvement not only in conductivity of an electrical impulse, but we're seeing a very strong trend in functional outcome with patients. And we measure this functional outcome by something called GRASP, GRASSP, which stands for Graded Redefined Assessment of Strength, Sensation, and Prehension. And what GRASP is, it's a series of assessments specifically to people with spinal cord injury, and it measures upper limb or hand function. So GRASP is probably a very appropriately named to look at hand function and grasping. The main domain that we were looking at, or the main domain of GRASP, is a portion of it called prehension performance, which is a direct measure of hand function. And this is really activities of daily living. So if you're, so the question is what is important to a person with a spinal cord injury? And it measures things such as pouring or picking up a bottle of water, locking or unlocking a door with a key, putting a key into a lock, or putting a screw on a nut and then being able to tighten it up. And what we saw with NVG-291 treated individuals in this study who received, as we discussed, it's given as a subcutaneous injection in the abdomen for 12 weeks. What we saw is a 2x improvement over the placebo arm in GRASP total score, which is a reflection of the upper limb function. And then we saw a 9.3x improvement over placebo in what's called prehension performance. And this is a reflection of the direct improvement in hand functions of daily activities of living, which I just discussed, which is nut on the bolt, or, screwing that on, or putting a key in a door, or pouring water into a cup and then drinking the cup. And these results are very, very important because, when you look at two things that people can't live without, two functions that we rely on so much on a day-to-day basis. Number one is vision, and number two is hand function. And so GRASP is measuring this hand function.
Is this a test that you all have developed, or is this an industry standard test? It sounds really accurate.
We did not develop this test. It's a test that can be purchased, and it measures those three functions plus a 9-hole peg test. Some of them are measured by time. Some of them are measured by accuracy. And so it has been specifically developed for individuals with spinal cord injury to test them in a clinical trial.
I want to clarify, spinal cord injury might affect the lower body as much as the upper body. Is that correct?
That is correct.
And so are there also assessments for mobility?
There are, and you can look at endpoints such as strength. You can look at endpoints such as muscle spasticity. You can look at walk speed, although that tends to not be a very accurate, or as in a 10-meter walk test, but that's not as accurate.
And so the interesting thing, additionally, about your study is that you enrolled students with patients with chronic spinal cord injuries. So is that population more difficult to treat than patients with newly acquired injuries?
Actually, that's a very interesting question to ask. And when you look at the natural history of spinal cord injury, Karen, there is a real world evidence and literature that people with spinal cord injury plateau in their recovery after 6 to 9 months. If you were to ask Dr. Silver, Jerry Silver, who is really the inventor of what we call NVG-291, he would emphasize that when it comes to recovery, it's less about the time from injury and more about freeing the entrapment of chondroitin sulfate proteoglycans, or CSPGs, that enable the nervous system to repair itself. So if you can really interfere with the inhibitory pathway of CSPGs, it really doesn't matter how far out someone is from the injury. So it's really irrelevant how long they're out. It just matters whether you can enable the neurons to circumvent the CSPGs that are there. And that's how NVG-291 works.
And so those results just confirm Dr. Silver's hypothesis. Is that right?
I would say absolutely. And what's remarkable is the similarities that we see between our preclinical rodent models. And I'd even take a step back and go into when Dr. Silver looked at growing neurons in a petri dish that had CSPGs. So we've seen, if you add what we call NVG-291 to the petri dish where a neuron is sitting there with a layer of CSPGs and they can't regrow, you put the drug in, they're able to grow through the CSPGs. We see improvement in the rodent model of, spinal cord injury rodent model. We see improvement in animals there that are treated with NVG-291. And now we're seeing that translate into humans, in our study. And so this successful translation from animals to humans gives us really a lot of confidence and hope that we will open up the possibility of a new world for individuals with spinal cord injury.
And so spinal cord injuries, as we said earlier, are really unique, differing from person to person. And I'm wondering how that affects the way you can design your clinical trials, and particularly when it comes to younger people who might have car accidents or sports accidents versus an older person who might have injured themselves through some kind of fall or car accident.
Well, definitely when you bring up you're discussing really there's a bimodal distribution of age that's affected by spinal cord injury. So you really have a blip of individuals that are late teens, early 20s, and those are usually traumatic accidents like a car accident or a sports injury of that nature. And then you get another blip a little bit later in life after 50 to 60, And those are older individuals that have falls. So the average age is somewhere in the 40s. But it's really what you get are these two blips of age. But I don't think age really has any effect here. Obviously, we're dealing with a very heterogeneous injury, and obviously it's difficult as no two injuries are the same. No one's ever going to experience same location of the injury, same force, same mechanism of injury. And that's what makes this inherently difficult to treat, say compared to a genetic disease where some people may have some differing severity or they may be at a different stage, but the disease goes down a fairly typical path. That's not the case here. So when we designed our phase 1b/2a, what we call Connect SCI study, with a focus on cervical motor incomplete injuries, we attempted to create, we attempted to create a homogeneous study population in the setting of a very heterogeneous, injured population, if that makes sense. So it's not that easy. But at the end of the day, what we're really looking at here is we want to look at the functional outcome. And we really believe that regardless of the type of injury, the force of injury, the location of the injury in the cervical spinal cord area, that we're going to have an impact on those individuals as well. I think one other note, I think it's important to note in its totality that we ultimately at NervGen are going to have the goal of focusing on the entire spinal cord injury population, not just what we enrolled in this study, which was motor incomplete cervical spinal cord injury patients. The homogeneity of the cervical motor incomplete population, that offered us really the strongest potential for success in an early clinical trial setting. Also, most individuals with spinal cord injuries do have cervical motor incomplete, but by no means does that mean that we as an organization are going to ultimately focus only on this population. Our goal is to impact all individuals and treat all individuals with spinal cord injury in the future.
And that leads me to ask about treating neurotrauma, such as traumatic brain injury. Is that also a part of the bigger story here?
Absolutely. I really view NervGen as the CEO as more than just a spinal cord injury company. I view us as a neurotrauma company. Our drug NVG-291 has shown efficacy across multiple models of neurologic trauma, and that includes, we are even testing it in collaboration with the United States Department of Defense. We've done a number of studies in what I would call neurotrauma. I'm going to list these off for you here, but we've done a traumatic hearing loss model from blast injuries. And in that study, NVG-291 significantly reduced hearing thresholds compared to placebo across all blast frequencies. We also have evaluated it, meaning NVG-291 in a peripheral nerve injury model, where NVG-291 significantly improved neuromuscular function and axonal regeneration. And by the way, in these first two, there's really no treatment at all, whether it's for blast injury, hearing loss, or for peripheral nerve injury. There are no good pharmacologic treatments for these entities. And just to preface this, these are all in animal models. And then in a severe animal stroke model, NVG-291 has shown improved motor and sensory function as well as memory, even when treatment is delayed up to 7 days. And that's been replicated by a number of different academic labs, not only in the U.S., but worldwide. So I feel very strongly that while we're focused on spinal cord injury at this point in time, as the company matures and as we progress NVG-291 in clinical trials for spinal cord injury, we're going to continue to evaluate the positive benefit in neurotrauma. So I really firmly look at us as a neurotrauma company in totality.
It sounds like you're working with some basic building blocks there as well to understand how the body reacts to such an injury. So is this also leading to perhaps another realm where these kinds of conditions can be seen as treatable and seen more as chronic conditions rather than really life-threatening diseases or injuries?
Well, it's hard to say. I think at this point in time, the injury models that we've seen are really more in the acute stage. And I'm not referring to spinal cord injury, but I'm referring to the blast injury or peripheral nerve injury or stroke. In those models, timing seems to be more of a factor, and treatment at an earlier stage within a week tends to have a greater benefit.
Well, before we run out of time today, tell us a little bit more about your background.
Oh, my background, yes. So I'm a physician by training. I went to medical school at Emory University, did all of my ophthalmology training up in Boston, first at Boston University Medical Center. and then did fellowship training at the New England Eye Center, which is at Tufts Medical Center. I'm an ophthalmologist trained in retinal diseases, primarily retina surgery. Really around, I was in practice. I remained in practice at Tufts Medical Center and had a large practice in eastern portion of Massachusetts. And around 2005 to 2007, started a company in gene therapy for advanced age-related macular degeneration with geographic atrophy, which I really put that very similar to a disease like spinal cord injury. And the reason I say that is that in macular degeneration, especially the dry form, we had no treatment. There was really nothing that we could offer individuals with advancing geographic atrophy. And unfortunately, I would have to sit in my exam chair talking to a patient and letting them know that over the next 6 to 12 months, you're likely going to lose your vision, which means you're going to lose your ability to drive. You're going to lose your ability to recognize faces, play cards. And so I wanted to provide individuals that really had no hope, some hope that we could maintain their vision for the rest of their life. And I look at spinal cord injury and NervGen and NVG-291 very similar to that. I'm bringing what I brought in my ophthalmology training and in my running my company Hamira Biosciences. I'm bringing that to NervGen, where we're bringing a drug, NVG-291, that was really developed for the most part, or shall we say, like conceived in the lab of Jerry Silver, and we're bringing that to market, or bringing it to clinical trials, I should say, and bringing hope for individuals that have no hope with spinal cord injury. Because really right now, an individual that has spinal cord injury, when they come in, they're medically and they're surgically stabilized, let's say at a hospital or an emergency room. They then go through 3 to 6 months of physical therapy, occupational therapy, some form of recovery. And then for many individuals, unless they are very highly motivated or they have really good insurance, they're sort of left to their own devices and, working out on their own. Exercise definitely improves individuals' outcome, but that exercise, there is a ceiling to that exercise. So I look at NVG-291 as I like to say, our mission, and I'm a very mission-driven person, our mission is to improve the lives of individuals with spinal cord injury. And so I think I look at this drug has the possibility, as we go through additional clinical testing, this drug has the ability to further improve the lives of individuals, whether that's improving hand function, improving leg function. It's going to give someone that additional benefit that's going to improve their lives, whether it's I can now put my sweater on and button it up. I can open up my medication. I can type on a keyboard and move a mouse. But that's really it. And also bladder quality as well. Bladder function is very important. And we are looking at a lot of the exit interviews that we've done with individuals. And it's very, very important what we're seeing that they are improving their quality of life. If you don't mind, I want to just tell you one, as we continue to analyze our efficacy profile, Karen, we did an IRB approved exit interviews with every participant, whether they received NVG-291 or didn't. And one woman in our study, who was years out from her injury, she was treated with NVG-291. She received the drug subcutaneously on a daily basis for 12 weeks. And basically what she said is the easy part is being in a wheelchair. And I found that fascinating because I think most people out there would think, oh, what does a person with a spinal cord injury want? They're going to want to get up and walk. She said, no, the easy part's being in the wheelchair. The hard part is getting up each day and struggling to put on your clothes, struggling to button your cardigan in the fall, and struggling to open your medications on your own on a daily basis. And so that's really that's what we want to change. We want to change the world that individuals live in, where they're given more independence and can do what they do on a day-to-day basis, so they don't need someone helping them at all times.
Thanks to my guest today, Adam Rogers, CEO of NervGen Pharma, NervGen.com. I'm Karen Jagoda, host of the Empowered Patient Podcast. Thanks for listening, and we'll see you next time.